Hi, I'm going to start the final panel. So before we begin, I'm pleased to introduce the moderator of our closing panel, Dr. Chandak Ghosh. Chandak is a board-certified eye surgeon and captain in the U.S. Public Health Service Commission Corps. He has served 3 presidential administrations at the Health Resources and Service Administration, HRSA. Among many things at HRSA, he has worked on the design and implementation of the Affordable Care Act and the development of the National Performance Review Protocol that's utilized to evaluate federally funded health grantees. Chandak has also authored numerous landmark publications focused on minority populations, including a National Health Agenda for Asian Americans and Pacific Islanders that was featured in the Journal of American Medical Association, JAMA. His findings were presented before Congress and the White House and has really energized many collaborations among foundations, community-based groups, government, and academia. And recognizing his achievements, the U.S. Public Health Service awarded Chandak an Outstanding Service Medal Award, among its highest honors for influencing progress towards health equity on a national scale. He's received this award 3 times. We've had the privilege to work with Chandak on a number of community-engaged research and dissemination initiatives and can attest to his personal commitment to advancing health equity. Please join me in welcoming Dr. Chandak Ghosh.
Good afternoon, everybody. Hopefully you had a great conference, and we're going to end with a great panel that will hopefully solidify everything that you've learned today. I've learned so much today. Hopefully you have as well. When I started my career about over a decade ago, myself and other colleagues who are interested in Asian American, Native Hawaiian, and Pacific Islander health were entering our careers at a time where the nation was focused finally on minority health and the disparities found in different groups, different minority, ethnic, and racial groups. So we were excited to be entering a career at that point. But when we saw large data sets from government or academia, we would see under the Asian American Pacific Islander column, data not recorded, or data insignificant, or data just pertains to all Asian American Pacific Islander, which was really useless for progressing our health as individuals in this group. So we at least were trained at that point to realize that what that really meant was that we weren't being counted. We weren't being tracked to see how our health was really doing. And you can call it a lot of things like data not collected or data not significant, but that's really what it means. And policy was being created without knowing what our health status was. So we did what myself and colleagues, many of who are in this room, did what we know how to do. We wrote papers, gave speeches, wrote books, ringing the bells to inform our community as well as the rest of America that this is a situation that cannot stand, particularly since we are the fastest growing minority group. And what's going to happen in 2 years, 5 years, 10 years, when you know nothing about this population. So we would write papers that would say, you need to do X, Y, Z, and A, B, C, D, E, F, G to get to where other groups already have information. So in fact, when I wrote a paper, I sent the final draft to one of my mentors, and she raised her hands up and said, "You're asking people to do all this work. Who's going to do all this work?" And at that point, I really didn't have an answer. But in the last decade, even though we've heard about today all the data that we need, there has been an explosion of data because of people like you, because of people, Asian Americans and our allies, within government, within academia, within community-based organizations have forced these organizations to count us, to look at us, to create initiatives, to create interventions, to create data with community-based participatory research. Everyone has stepped up, and we have a ton of research. So I want to introduce to you 3 of the torchbearers that are pushing this engine along. And I have Kathy Cochin, I have Clayton Chong, and we have Tung Nguyen. And we're going to talk about, well, most of today was talking about where we are now. And we're going to talk today a little bit about where we hope to be and how we're going to get there, and how we're going to harness the energy, the healthcare energy that's happening right now with the Affordable Care Act and such, to get to what we need to do. So before we start, let me have them introduce themselves to you. Tell us a little bit about who you are, and about where your passion is in Asian American, Native Hawaiian, and Pacific Islander health. So let's start with you, Kathy.
Thank you, Chandak. This is great to be here. I identify probably the most as being a child of immigrants. So both my parents came from China via Taiwan. And that, I think, really has shaped who I am in so many ways and really landed me here at the Health Forum, where I've been for the last almost 5 years. But really, my entire career has been in working in underserved communities, assuring that there's access to health, whether it be through an FQHC or being on the funding side and really trying to make sure that the resources are there. Chandak asked us to talk about our passion, and for me, I think it's about connections, and today is really a great example of that. If we look across all of us that are here, there are researchers, there are data analysts, there are policy people, but of course, there's also our community-based partners who are really, for us at the Health Forum, the heart and soul of our work. And if we really think of all of us together in this effort, really trying to move the dial, as we use the theme for today, to really have a movement and move things forward, it really takes everybody's efforts and kind of that appropriate division of labor where everyone has a role to move forward the data sets to really make a difference in the policy arena. And certainly for the Health Forum, the Asian Pacific Island American Health Forum, that's how we started. As I said this morning, was 29 years ago, the Secretary of Health at that time did a study that was seminal and looked at minority health issues, but found that Asian Americans were healthier than everyone else. But that was just because the data didn't show the needs that we had. And in many ways, now 28, 29 years later, so many things have progressed, and yet at the same time, so many things stay the same. So for the Health Forum, our enduring agenda has been around data. It has been around access to care, especially around coverage. It's also been around language access, which we'll talk about a little later. And then also really helping support our community-based organizations and make sure that they have the resources, whether they be the financial resources, the capacity resources, or the intellectual resources to be able to move their work forward.
Great. Clayton?
Hello, and good afternoon. It's great to be in the last panel. So I'll start off by telling you who I am not. In reference to my wife, I am not homeless. In reference to my oldest daughter, I am not a goat herder. And in reference to my youngest daughter, I am not Santa. Although I will remind you that if you've been bad, you have 2 months left to be good. Who I am is that I am a practicing oncologist, and I'm also a principal investigator of a network called Imihale, which is a community network program center. And it was funded by the NCI, by the Center to Reduce Healthcare Disparities. What I wanted to talk to you about was the census in Hawaii. And the census in Hawaii is different from that in the United States, in general, mainland United States. And this makes a huge difference when we look at data collection. Because in Hawaii, it is a state of where the majority are minorities. And the white population is about 26% compared to the mainland United States, which is about 78%. And the Asian population is the biggest majority. It's about 40%. The Native Hawaiian population is about 10%. So this aggregating the data is important. When you look at Hawaii in general, we look like we are one of the healthiest states. But when we look at the data and we separate Native Hawaiian, Pacific Islanders, you will see that a lot of this ethnicity population is way above the acceptable standards as far as obesity, heart disease, cancer, and their outcomes. So disaggregating data is extremely important, especially in Hawaii. But I wanted to talk to you about a concept, and a concept that I have heard mentioned in here, and so I'll use a few words, and it has to do with the 4 pillars that was first mentioned at the very beginning in the keynote talk. But it's a concept called indigenous chimera. Now, I don't know if you know what chimera is, but chimera is a mythological beast, and it is 3 genetically independent beings that live together. One is a serpent, the other is a goat, and the other is a lion, and they live together. And was slain by a warrior. And if you pass Columbia School of Law, you will see that they have a statue of Blepharon, who was the Greek soldier who slayed the beast. But chimera means that you can have two genetically independent beings living together. Native Hawaiians have actually improved their healthcare outcomes by adopting cultures that can live independently together. Last night I heard on the news that they're even talking about how this lava flow on one of the islands is overtaking a community. Well, in Hawaii, there is a term called kipuka. Puka means whole, ki means life, so whole of life. And what that lava flow will do, it will succumb certain areas, but it will leave certain areas behind. And over time, those areas that survive will spread life, and it will grow, and another forest will develop. And that is what has happened in Hawaii. Because of certain education, grassroots efforts, community coalition, and technology, they have learned to survive. And because of that, they have spread, and healthcare has become better for that community of Hawaii. So we can learn how to accept different cultures and live together. And that is a tool that I wish the young investigators out here will take back to their communities, to come here, disseminate data, learn from others, take that information back, and survive. And that's basically what I have to add as tools moving forward.
Tung?
Thank you. My name is Tung Nguyen. It's a great pleasure to be here. It's been a great conference. Learned so much sitting in the audience, and part of my job today is to actually synthesize some of what I heard a little bit. I am a professor of medicine at UCSF, where I actually see patients as a general internist. San Francisco is 30% Chinese, so there are lots of Chinese patients in my panel. I'm like one of only 3 or 4 Vietnamese-speaking doctors in the city, so I get lots of Vietnamese patients. So I have a little bit of experience with sort of day-to-day care of individual patients. I'm also the director of the Asian American Research Center on Health, where we do a lot of community-based statistical research project to address Asian American health. So I'm a little bit of a data person. And this year I was honored to be appointed to be chair of the President's Advisory Commission on Asian Americans and Pacific Islanders. And so I'm really interested in policy and helping to make change. A couple of things about me personally. I'm I think a lot of people know this. I'm a first-generation Vietnamese American. I immigrated here when I was young. That's one thing. Second thing is I'm a certified data wonk. Lots of us want to be data wonk, but I'm a certified data wonk because I have a certificate from the White House Initiative staff telling me I am a data wonk. And so I love to talk about data. I think what I'll do with my opening comment is one of the things that struck me sitting here in the audience talking about health equity, and I kind of want to pose this as a question to you, because we talk about health equity as if it's sort of something that's clear. And I think the question I wanted to pose to you was to think about a metaphor, or choose between 2 metaphors. One metaphor is, this is health equity, we're all standing on top of the mountain together, and we have the sun shining on us, and we're breathing fresh air. Okay, that's one metaphor. The other metaphor is we're all in the same boat together, and the boat's slowly leaking, and we're all bailing like crazy so that we don't sink, okay? So I think when we talk about health equity, we need to think about what it is that we're all are being equal or equitable about. So that's gonna come up as we're talking, some of my point making today.
Great, thank you. So let's talk about, well, first we've talked a lot about where we are now and how we got to here. Let's talk about where we need to go. Much of what we've talked about already is about data. We all understand we need data. But let's move a little bit past the data and say, once we have the data, then what? What do we need to do? Anybody chime in? Let me know.
So I've been thinking about this one a lot. Today, we hear a lot about disaggregation of data. And so I'll pose a second question, which is, for change to occur, is it disaggregation that's important, or is it aggregation that's important? And so so the way that I thought about this, and actually Michael, I don't know if he's still here, but when he was talking this morning, I was thinking about the value of disaggregation. There are three things that are very valuable about disaggregation, and one of them Michael taught me today. So the first one is needs assessment. You need to have disaggregated data to assess, all right? Second thing that's important is it's a way to make an argument to the power that be, right? So you go in and your community, you know what's going on in your community, and you tell them what's going on, and they're like, where's the data? And since you don't have disaggregated data, you're stuck with this idea that somehow they're thinking that you're just presenting opinions, not knowledge. And disaggregated data really gives you that power to go back and say, I have knowledge. But the third thing that's important, as I understood, is the lack of data for your community, our communities, forces us to learn how to speak to power, how to empower ourselves, and how to basically work with power so that we get more disaggregated data. So disaggregated data is actually not its own end. This is what I heard Michael talking about this morning. Like, we don't have the data, so we're going to figure out how to do it. And the process of figuring out how to do it is actually very important. So I think disaggregation is really important. But now that I serve on the commission, and we're sort of trying to represent all AAPIs, and we're trying to represent APIs from all parts of the country, the question that comes up now is, when do we aggregate again? Now, when are we a whole instead of just a part? And I have to tell you that, just this is my observation, is this country runs on more. So either you have more money or more votes. And if you disaggregate, you don't have as many votes as you think you do. And so for policy to change, I'm trying to convince people that we need to identify points where we can aggregate. Now, this does not mean that you lose yourselves in the aggregate. You can still, I mean, I'm a Vietnamese from Northern California, and I will always be a Vietnamese from Northern California. But a lot of times when I'm working, I'm an Asian American in the United States. And that's why I like to think about it. And I think for big changes to occur, small changes I think are okay, but for big changes to occur, we need to aggregate.
So I want to build on what Tung said. So, the Health Forum, is a national health policy organization. We have a DC office, and but we're headquartered in San Francisco. So in San Francisco, just as Tung is there as well, you just get a sense of, well, there's a lot of Asians, and we can all vote together as a bloc, especially in places like San Francisco. And then you go to DC, and you realize that Asian Americans, Native Hawaiians, and Pacific Islanders are just a drop in an ocean of policy debates and considerations. And so while absolutely we need to support, especially as Elise said, demographic reports that really can reveal what's happening in our communities and really speak to the specific needs and issues and opportunities and assets that each of our communities have, when it comes to really making a difference, when it really comes to having an impact in policy, we really have to come together. So as I was talking earlier about a passion for connections and all of us having a role, it's really for us to all see that we have a greater impact that we can all have together by really bringing all of our issues together and really making sure that our voices are heard collectively in the policy arena. And I think that's really an important part of looking forward, because if we can't come together and we just look at ourselves as each individually, we'll never have an impact in that policy arena, at least at the federal level. But even at the state level, we start to see that more and more. The more people come together, I'm thinking about Ohio or Georgia or Arizona, where people are starting to really organize or have really organized and really start to have an impact on what's happening in their states at the policy level.
Well, my collaboration in that is that I think on a global level that is important. I am a practicing oncologist. I have a dual professorship. I'm assistant professor at the university where I am a teaching attending, but I am also an associate professor at our research center, where my research is in whole genome expression and identifying molecular characteristics in tumors and looking at health care outcomes differences. Now, we all know that African American prostate cancer is different from regular prostate cancer. It's a much more virulent disease. And we should know that Asian adenocarcinoma of the lung in females have a different genetic expression, and they may not need chemotherapy. So there are differences in biologic expression, and I think this kind of information is important. And when this kind of information is found, it needs to be disseminated on the global level so other people understand. And this is some of the kind of research that I do. So I still think looking at small bits of information, disaggregating the whole data becomes important.
So basically, we disaggregate in order to do health, but we aggregate to do politics, right? So knowing that, how do we harness the energy we have now with healthcare? Everyone's talking about healthcare, the Affordable Care Act, pro and con. What do we need to do as a population, as a political population, to get ourselves more advanced in getting more health policy toward Asian American Pacific Islanders?
I have an example. So at the Asian Pacific Islander American Health Forum, we're very, very proud to be part of a national collaborative called Action for Health Justice, and many people in the audience here are part of this collaborative. The national partners are APCHO, as well as the Advancing Justice Network, along with the Health Forum, and we work with 70 different community-based organizations and federally qualified health centers in 23 states, helping to educate and do outreach on the Affordable Care Act. And we help to assist over 230,000 people to enroll in the Affordable Care Act, health insurance coverage expansions, in 41 languages. We're very, very proud of this, and we're very clear that if our partners hadn't done that very hard work on the ground, in some cases taking 2 or 3 or 4 hours to help a family enroll, and doing it in the 40 different languages, that it would not have happened, that those individuals and families would not have gotten access to the healthcare coverage that they now have. So we're really, really proud of that. And then what does that mean? It means that not only are those 230,000 people's lives improved because they have health insurance, but now we have this national network that we can call upon for a variety of things. And so one of the things that we were asked by Homeland Security and the Immigration Service was, could our network then reach out to young people, dreamers, and see if we could help use this network to try to register those dreamers who qualify for deferred action for childhood arrivals. Meaning, if they register, then for 2 years they don't have a threat of being deported. So you can see then this opportunity is using this broad network from so many different states that is doing the critical work in enrolling people in health insurance, but now can be utilized for other important policy agenda items across the country. And we really feel that the future of that kind of infrastructure will really help us move forward in our communities.
You know, thanks for bringing up the Affordable Care Act. I think sometimes we forget how far we come. I think Chandak was just saying that, you know. Imagine, you know, last year, 10 million people, no health insurance. What could you have done on our own that would have gotten 10 million people health insurance? We recognize from the Commission and the initiative that there have been problems with Affordable Care Act enrollment. There's no question that there are lots of problems. And I think, for example, Action for Health Justice has done a really great job of help mitigating a lot of those problems. And there will be ongoing problems. But I think what the Affordable Care Act and its passage really taught me was the power of picking a topic that was really cross-cutting, that we all can get behind, right? I can't imagine anyone out there who, whether you're Vietnamese or Chinese or whatever group you want to identify yourself with, would have said, health insurance is no good. You know, we picked that as sort of the, you know, the point. And I would ask us to actually think creatively. You know, this is a conference on social determinant of health. And, you know, I was waiting to hear labor and income come up as a topic. And actually, I got it. I went to the integrated care session, and Nolan started talking about employment as part of mental health. And I think, you know, there are policy initiatives we can get behind. Now, we can talk about, you know, raising the minimum wage. Why not? A lot of our API people are minimum wage worker. They are. We can talk about gender gap. You know, API families are based on their women. You know, the women runs the family, and they don't make as much money as the men. You know, why can't we get behind that? So I think we need to pick topics that we all can get behind, and then, use the Affordable Care Act as a picture of how this could get done that can benefit everyone.
In Hawaii, in the 1970s, they put into law something called prepaid health. And for all employers, if your employee worked more than 20 hours, which was more than part-time, healthcare insurance was provided, mandatory. So we have been ahead of the Affordable Care Act by 40 years. And that has improved health in general in Hawaii. And actually, the prepaid Hawaii plan is better. It's a higher tier than the Affordable Care Act. So people in Hawaii have a choice. And who would want to give up a better plan? No one. But it does help individuals that are uninsured be able to get some coverage if they meet the criteria. It has not been as successful because it's so complicated. I mean, who knows what do you want? Gold, bronze, silver, and the explanation. So that has been a burden. But I'm sure that will be worked out. I kind of cheated this morning and I had Dr. Palafox talk a little bit about COFA. Because the migrant Micronesian population are where Native Hawaiians used to be 20, 30 years ago. Unemployed, no health care coverage, and their health poor. But because of the Affordable Care Act, I do believe they're a little better off. The free associated Micronesian population can travel between states, but they do not have federal funding for Medicaid, and they come to Hawaii without any insurance coverage. And what happened in Hawaii was they have an allotment of around $10 million to give to Hawaii to help with education and other means, which does not even cover the cost of the population in Hawaii. And it is estimated that we spend about $150 million covering that healthcare cost. So in Hawaii, what we had to do is create something called a Basic Health Hawaii, which is not a good coverage, but these are tools that certain states have to adopt in order to meet these demands that are coming forward. So the purpose of conferences like this is for you to hear what is happening in other places and understand, and together we can aggregate this data and move policies forward.
Just as an aside, earlier this morning, in the morning session, someone brought up, well, although we have ACA, what about undocumented immigrants? So coming from the U.S. Department of Health and Human Services, just let everybody know that the people who wrote the legislation understood that there would be a large number of people that would remain uninsured under the law. So they added $11 billion to help increase the number of community health centers. And for those who aren't familiar with HRSA-supported community health centers, there are 9,000 sites around the country that see about 20 million people. They provide complete primary health care without regards to immigration status, ability to pay, insurance status. So if you know someone or you are an undocumented immigrant, you can go to one of these health centers without having to pay anything and get complete primary health care. So if you go to HRSA.HRSA.gov, put in your zip code, you can find the community health center near you. And again, $11 billion went to increase the number of health centers, to take current health centers and increase their capacity, because there's an assumption that there'll be more people needing health care as well as more undocumented needing health care. That's an aside. So as we know, insurance alone, which will get you access to medical care, will not make everyone's health better. And the point of all of this is to make sure our communities have the best health outcomes we possibly can. So what are ways we community members and activists and advocates can work to help our communities get healthier with the ACA in the background? But there's so much more to becoming healthy. So what are some things we can do?
That's perfect. So when Action for Health Justice first got organized a little over a year ago, and Priscilla Huang this morning had talked about the mission statement. We also identified 5 pillars of what we were going to work on. One was outreach and education, the other one was enrollment, another one was monitoring and enforcement, because there have been challenges, as we all know, with language access and really non-discrimination issues. In fact, we were party to a Office of Civil Rights complaint about language access, and there's a lot to be talked about there. Another one was resources so that we could use technology to communicate across the country and help share best practices and tips on how to deal with healthcare.gov when it wasn't working. But the 5th pillar was service delivery for limited English proficient newly enrolled. So we already knew, because we know what the law says, that the limited English proficient, that having an insurance card was not going to be enough. That we know that there's not enough access points for the newly insured in general, but especially for limited English proficient individuals in our communities. And as the morning panel cited, or at the afternoon panel cited, the vast majority of our communities are limited English proficient. So what we've been working on at the Health Forum, and have partnered with APCHO and NAPIMA and the National Council of Asian Pacific Physicians and NAPAFASA, is to start looking at this question of how do we help the newly insured then access the care that they're now covered by. And looking at, in particular, when we think about what Dr. Murthy said this morning, really looking at community health workers, the concept of indigenous workers, whether they be promotoras or community health workers or patient navigators or case managers, but people who know, who are trusted partners in the community, who know their community members, who speak their language and understand the culture, and have them help literally navigate the healthcare system so that they can understand it. We look to some new policy opportunities to help reimburse this class of workers. Medicaid has said that they would help pay for community health workers, but it's up to each state to adopt that. So we're looking into whether or not we could push on certain states to be examples of that. We're also talking with some of the health plans to see if that could be a potential reimbursement mechanism. But this idea of how to now say, okay, if you're now insured, that's still not enough to be able to then get the kind of access to care that you need to get.
So I'm actually going to be kind of blunt here. So all these people, these 10 million people who got coverage now, nobody wanted last year, all right, because they didn't have insurance. So now everybody wants them. Okay, and everybody wants them, and a lot of them are minorities, APIs in particular. And so they want them. Whether or not they can provide care for them or not is another issue. So I think one of the charges for all of us in the community is to steer people to community organizations, clinical care organizations that actually already are culturally competent. I think this is actually a big problem, because I think what's happening is some of our, basically right now, our FUHC and our community health centers already had a really nice niche in the market. They took care of people that nobody else wanted to take care of. But now these people are, they're dealing with the challenge of keeping these people now that they have health insurance, right? And there's also sometimes in our community there's this idea that the community health center is only for the poor. It's not that good care, which is not true. It's absolutely not true at all. And so as soon as I get health insurance, I go find some private provider or big medical centers, which I work at, to get care for them. But we're not very good at that kind of stuff. We're just not. And so one of the things you could do as you're helping people enroll is also to think about, once you have an insurance, where do you go? Find providers. Hopefully there are some that are more culturally, they're not just, I don't like to use the term culturally competent, I don't know what that means, but they actually know how to take care of these people. And so make sure that they get into those situations where they actually get good care. So I would definitely think that there is more to be done. Language access is, I think, the first pass. The other challenge, and I just want to bring this up just because we're in a clinical care setting, is we're talking about things like surveys. And as a researcher's point of view, you guys are way behind. The world's going to look very different in 5 to 10 years, to be perfectly honest. Surveys, we still need to do them, all right? But surveys are much harder to do. If you ever try to do a survey nowadays, it's terribly hard. Nobody answers their phone. Everybody uses their cell phone. You use the internet. All these methodological questions, researchers are beginning to go, why are we doing this? We need to do it, but why are we doing this? The data that's going to come out in the next 5 to 10 years is going to come out from 2 places. One is what Dr. Chong was mentioning, which is genomics. Okay? Personalized medicine is going to come. And unfortunately, because for a lot of different reasons, minorities are not really part of this movement just yet. And what will happen is if personalized medicine really, medicine designed based on your genomics and your sort of biological profile, when it comes, it will create more health disparities, okay? Because just by just the virtue of the fact that we just don't have a lot of minorities in research and this kind of stuff. So that's going to come. The other side of the data divide is electronic health record is here. So big data is here. They're going to be able to collect, this is a hope, right? To collect millions and millions of data on patients. Whether or not you say you want them to collect it or not, it will be collected and they'll be analyzed hopefully, in the right, privacy and so on and so forth. It's being collected. And I think in one of the other meetings, one of the other breakout session, we were talking about, well, how do we know that the data they're collecting in the electronic health records reflect our ethnicity and our language and our sexual preferences? How are we going to be able to capture all these things that make us also unique? And we need to be thinking about these things. I'm really challenging you all to begin to think beyond just the easy, it's already hard. The surveys are hard already. We can't even get the right survey for the right people. But we got to keep on moving. We can't just stop here.
What is the real world like? In the university setting, you are immune. You have been vaccinated by funding. But in the real world, the hospitals and the physicians are at this time forming alliances. And because they have to form alliances, reimbursement is dropping. And insurers, believe it or not, are collecting, and Tung had to bring up the word big data, and they are collecting data. They are using scorecards, and smaller hospitals, there are buzzwords, cost, safety, and efficiency. And those are the words that they want to hear, that we're going to give you a safe program, we're going to be more efficient, we're going to cut costs. And based on those premises, they form alliances, and what they want is lives. They are looking for what hospital will get the most lives so that they can look at their analysis, give them incentives, score the physicians, and give them a percentage of what they save back as incentive reimbursements for saving their money. And this is what's happening universally. And you can ask your physicians who are they allying with, because in Hawaii we ally with our biggest insurers there. They will guarantee us certain incentives if we can save money, we can improve quality of care, and we can serve as many lives as we can. And this is where healthcare is moving.
I'd actually like to go back to the topic, Chandak, that you talked about just a minute before, which is immigration status. It is built into the Affordable Care Act that immigration status is now the single greatest social determinant of whether or not you have health insurance in this country. And it is permanently there until we make a change. So undocumenteds are completely left out of the Affordable Care Act expansions. And as Priscilla Huang, who you heard from this morning, likes to say, is it's as if you go to the grocery store to buy a gallon of milk and they ask you your immigration status, meaning you can't buy health insurance on the exchange just because of your immigration status. So we've got that. We still also face the 5-year bar for Medicaid eligibility. So that's if you are a legal permanent resident, you have a green card, and you're here less than 5 years, you're still not eligible for Medicaid, except in those 13 states where the states themselves pay for that Medicaid. So we've got 34 states where you still can't qualify for that. So again, immigration status is being the determination as to whether or not you can get affordable care or public health insurance. So really immigration reform then becomes the key solution to that. We are all still waiting for the president to provide administrative relief through executive order, which will probably happen after November 4th, Election Day. And we hope that it looks something like DACA expanded for the family members of the Dreamers and those who have citizen children. Another piece of it would be to think about how those who register to become deferred action, whether they be Dreamers or their parents and family members, could then get access to health insurance, either through the marketplace or qualify for Medicaid. So all of these, none of these things are health policies per se, but are very, very germane to our communities. They're very relevant to whether or not people will get insured and whether or not they'll get access to care. So as we think about social determinants, as we think about health and all policies, the concern that all of us should have about immigration reform is really, really important.
Can I jump on that? I think that's a really important point, and I've learned this actually serving on the commission is, if you're doing health and all you're doing is health, you're probably not doing health. Does that make sense? It's just a really Zen saying right now. Because really, immigration is health, right? Employment is health. Education is health. You need to also reach out to other activists doing these other things. And I think that's the idea behind collaborations, there's another way to aggregate, not just to aggregate by ethnicity, but to aggregate by skill sets and constituents. And so I think that we need to be talking about immigration in health. That's
great. I don't know if you noticed, but our panel is divided. You have 2 physicians and you have a public health expert. And the public doesn't realize, I assume you're being here, you do realize that there's a differentiation between medical and preventive care. And medical is you wait for the disease and you treat it. Public health is about prevention, healthy communities. We heard about walking and not smoking and eating well. That's all public health. And really to improve outcomes for an entire population, you have to combine both. And I think we heard both points of view, the public health and the medicine coming together. So let's stop this panel for now and ask if there are any questions for our people. Come on up.
Chandak, while we're waiting for the question, can I just make one
sure,
big pitch? Because otherwise the initiative staff's going to get me. So we did want to just mention 3 or 4 things that the initiative and the commission has been doing that I think you should be aware of, just to make a pitch.
This is a White House initiative. This
is a White House initiative. So first, data.gov/API. How many people have heard of it? Okay, we've been talking about data all day, so you gotta know about this, right? So data.gov/API. So we're gonna try to put together as many data set that is relevant to API, and that's not just health, it's across the board on that website. So you can go, before you tell us you don't have the data, you need to go there first and make sure you don't have the data. Because actually it turns out, a lot of times there is data out there, maybe not exactly for your population and your community, but it's close enough, right? So maybe that's the case. We're also hoping that you'll look at that and you'll say, hey, there's a lot of stuff missing here. And that's going to be an impetus for us to get more things done. Second thing I want to make a pitch for is that the initiative is working with a lot of local organizations on capacity building and grant making and technical assistance. So keep an eye out for email. If you're not on the WHI AAPI listserv, you need to be on it so that you can get information about this. And then the last thing is actually a very major initiative that we're doing that I think you all would appreciate, along the line with this aggregation of data, which is the Regional Interagency Working Group. So the initiative works, basically the commissioner and the initiative work together to connect the community to the federal agency. But in the past, the connection has been in DC. In other words, with the main federal agency that's based in DC. And what we learned, particularly for APIs, is a lot of stuff that goes on in the region. So the federal government's divided into multiple regions. How many, Chandak? 10?
10 regions.
10. I always get that number wrong. 10. And a lot of the work actually goes on in the region. And so the initiative has now become very committed to this idea of getting you together, the community organization, together with the federal agency that's in your area so that you can actually communicate directly with them. And it's an interagency working group, so this idea of not just working on health is actually very important. You get to meet labor, you get to meet civil rights, you get to meet all kinds of people there. And I think that's where some of these great ideas are going to come out of. It's when you meet all these different people. It's amazing. We had a meeting in San Francisco or in Oakland, and you would think that API community organization in Oakland would be really great at knowing to navigate the federal government, and they did. They were just amazed at how much is going on. So please stay in touch with us for that. That was just
great. And I'm on the regional interagency group for New York, so from the New York region. So, and we're meeting tomorrow. Okay, question.
Okay, I think we're good. Okay, so hi. Thank you to the panel. My name is Minja Hong. I'm from Korean Community Services of Metropolitan New York. From the beginning of the ACA implementation, we've been working in New York and New Jersey. So I'm also a certified certified on the federal marketplace as well. I think we're one of the only organizations that can work on both the federal marketplace and New York State marketplace, and that's all thanks to the Health Forum's help, so thank you so much again. And I'm so excited to see that the end panel today is made up of so many physicians, because the question that I would really love to pose is, how can we, understanding that and recognizing that so many of the considerations for our communities is that ethnically, culturally, and linguistically appropriate care is so important. How can we start to engage the ethnic providers in our communities to, take a leadership role? Because right now, it's funny that you mentioned surveys, because we are actually reaching out, because we don't want this to be a punitive measure, obviously, to the medical care providers in our community that serve our community members. And, a lot of them were getting mixed responses from lack of information, a lack of insurance companies reaching out. How do you propose, as physicians yourselves, that we start to engage them in this conversation?
Let me go back to this chimera thing that I talked about. Because I'm an oncologist, I use cancer. Well, leukemics, their cancer is in the blood. In order to cure them, you have to get rid of that malignant blood. And if you treat them and you take that bone marrow and you save it and give it back, you might be successful. But if you eliminate the malignant bone marrow, but you take bone marrow from another person, you are much more successful. And one would wonder why. And the reason for that is when you inject somebody else's bone marrow into you, it stimulates an immune response called a graft versus tumor response, which means that body's immune system will generate an immunity to combat the cancer. In cultures, the success in Hawaii has been because multiple different cultural aspects came together, and what Tung talked about, if you treat health with health, you are not treating health, is absolutely correct. Because part of that included schools, education, included businesses, employment. And if you do not have all of that together, you're not going to have a healthy population, because just treating the disease is not enough. You have to treat the individual. They have to have a job. They have to have income. Those are all the social determinants of health. So you need to engage your cultural individuals that collaborate with them to be informed that that is as important as treating them themselves. And the physicians need to become engaged.
Can I be clear about what you're asking? You want to engage ethnic physicians to do what?
Right now, one of the big, most people can hear me. Right now, one of the biggest concerns for those, even outside of the Medicaid expansion in New York and New Jersey, for that matter, is that a lot of the doctors, the ethnic doctors who offer culturally and linguistically competent care, are not accepting the plan.
Absolutely.
And they don't understand whether this is a mandatory thing, whether the insurance companies need to reach out to them, whether they need to reach out. And often, we want to know from physicians yourselves, what would engage the providers more to look into.
Yeah, I think you're pointing out a very important issue for API Health, and that is our provider pool is going to shrink pretty rapidly for culturally and linguistically competent care. It's much, I'm fond of saying, I'm okay with taking an okay doctor who speaks the language and try to get him to be a better doctor, and to take a really good doctor who don't speak the language and trying to teach them the language. So we need to preserve our ethnic physicians, and I think it's sort of a big challenge, right? Because most of them are solo practitioners or small group practitioners, and the ACA really has made it difficult. They have to implement electronic health record system. They have to implement a lot of concepts, and there are lots of pay-for-performance kind of issues. And they're getting, they're not sure how to deal with it. Most people go into medicine not to be business people. They go into medicine to practice medicine. And it's gotten very difficult. I don't have a great answer to your question, but I think you do need to engage them. I guess I would point to the National Council on Asian Pacific Islander Physician, which is the group that actually deals with this issue a lot. They've been struggling with this issue and addressing it for many years. So I would recommend you contact them and figure out what they've done in terms of needs assessment and sort of communication techniques.
Next.
Thank you very much for all of your advice and wisdom. My name is Anh Vu Sawyer. I am the director for the Southeast Asian Coalition of Central Massachusetts. We started in 1999, and I think it represents a very large number of grassroots, community-based organizations. They also called us the gatekeeper because majority of immigrants and refugees and low-income American Asian and in our areas would come to us first for cultural and language reasons. However, we found that we were the last person that got any kind of resources so that we could be most effective to help our people. And I think all of the ideas and suggestions that and data collection and all of that I gained today could really be applied at our level to every person in the American Asian communities. How would you suggest for people like us and organizations like us to be empowered so that we will be able to be out there and help our people? Because right now we're just so limited to the point that we know mental health is needed. We know other basic needs is needed. We've seen all of this, but we don't have the resources or the backup for us to be heard out there by foundations or funders. Thank you.
I think the key thing is about connecting, connecting with other people doing the same work, connecting with other folks in your state. Certainly in Boston, there are a lot of different resources, community-based organizations who you could partner with. And I know that we at the Health Forum have been reaching out to your organization as well. So those kind of connections can really help build the capacity of community-based organizations over time.
Okay, we only have a few more minutes, so these two are the last. Go ahead.
I want to thank all of the presenters. I really enjoyed listening to you speak. And I was really delighted to hear you talk about social determinants and also about big data. But I think one of the barriers is we can collect data in specific databases, governmental websites, and things like that. But all those data are siloed. I mean, if you're really serious about thinking about social determinants and connecting that with big data, we've got to connect NHANES to databases from the Department of Education and the military, et cetera. And because all those things are stuck in their own firewalls and their own agencies, we'll never be able to ask the really deep questions that we would probably want to ask. And I guess part of my comment is to see what your thoughts were about that.
We have met, at the Health Forum, we have met with the head of the HHS Data Council, and they are part of the larger federal statistical community, and that's really what they call themselves. We at the Health Forum have done analysis that takes census data and National Health Information Survey, interview survey data, and cross-tabbed it. But it took a year's worth of getting all the FBI clearances to be able to do that. So there are a lot of challenges with community-based organizations or even researchers accessing that data. And so I really do encourage the research community to really continue to advocate for how to not break down the walls, but really try to figure out how those federal agencies can collaborate so that those data sets could actually get analyzed in a cross-tabulated fashion. And then certainly those of us who are data wonks and advocates can work closely with researchers to really push on that. It really will take the strong voices of those of us who work with data to really push on and make that change.
Yeah, I think data.gov/API is the first step toward this vision, this utopia, this data wonk utopia that you're talking about. And we have to keep on pushing on it. I don't think we're going to have it anytime soon. I'm waiting to see how they're going to implement population health across the EHR first. to how to get each of the EHR to talk to each other, which is actually something they have to do, right? I mean, it's
Eventually.
right.
Eventually, yeah.
Eventually. So that we'll see how they handle that technological problem first.
Great. Last question?
Yes, one of the questions I have for the panel is that in this dialogue on disparities and health equity, I think you're really preaching to the choir, but there's another half of the nation that is trying to take apart the ACA. There's a lot social equity, like we discussed, and disparity issues and social justice as a value. It's a value-laden thing, and lots of people, frankly, don't believe in it. I don't think. I mean, I just look how the nation acts, and so I think in this dialogue that you have, knowing that, do you just keep moving in the direction of? I mean, what is the reality of some of the things that you're saying coming to fruition, and the fact that you can see that the Senate and the House might change color and colors, so forth, and also I think a lot of the models we're using, frankly, depending on data, depending on current models we have, are frankly outdated. I think they're shown to be very difficult, very costly, and don't work. So as you're supposed to close this off and kind of looking at the future, I'd just like to kind of hear about some positions on that, because I think we need to know the other half of the story, that some of this is working very uphill, and if we don't reach where we want to go, what is the alternative models and directions, or do we just keep kind of, obviously you still got to work at what we have to work at, but I think we have to be aware that the next 10, 15 years might look very different from what's occurring now. So that's just a question.
I would just answer kind of quickly, actually. I used to be a philosophy major, so I have an annoying habit of answering a question with a question. So my question to you is, when was the last time you saw a voter registration booth in your hospital or your clinic? Okay? So if this is so important, how come we're just letting it go to someplace else? What Neil just said was basically, it's about the votes, right? And we're here. We're not here to tell you how to get the vote out. You know how to do that better than we do. But you got to get the vote out. The one thing that I've learned is that you can't fight change. Okay, change is coming. If you talk about gay marriage, for example, who saw this coming 10 years ago, right? So it's coming. Whether or not you like it or not, you fight it or not, it's coming. And demographic change is here and it's coming. It takes a long time though. So the question is, can we get the people out? And I think the answer to Neil's question is, you got to get the people out.
I actually have a couple points to respond to Neil. So one is, again, for the Action for Health Justice Network, not only are we doing enrollment assistance for the ACA and now whoever wants to help with the DACA registration, but we're also doing voter registration, because that's really, really important. There is the National Voter Registration Act, which says that for any program that the federal government supports, that an applicant should also be offered the opportunity to register to vote. So we are doing that as well. So absolutely building on what Tung is saying about that. The other thing, so I want to make a note that the Asian Pacific Island American Health Forum is a nonpartisan organization, but we also recognize the composition of the Congress and who is supporting the Affordable Care Act and who has done over 50 votes against the Affordable Care Act. But in terms of strategy, political strategy, one of the things that the Health Forum has worked on, in fact, our #1 legislative priority for the 113th Congress, was to get the restoration of Medicaid coverage for COFA migrants. What I have learned in sitting in the offices of Speaker Boehner's staff and talking with them is that we can't talk to them about the Affordable Care Act, and we can't talk to them about health insurance. But what we can talk to them about is strategic military position. And so it's learning to speak the language of those policymakers to make the case for why they should join the efforts that we're undertaking. So for COFA migrants, for the freely associated states, the treaties that they have are because of strategic military position. And talking about issues of defense are very connected to many members of Congress who might not otherwise think about the health insurance pieces that are involved. So what we have seen is at least an audience with some of these staffers who will engage in that level of conversation. And so it really is trying to figure out what are the right strategies and tactics in engaging members of Congress or policymakers so that they'll listen to you and really consider the policy recommendations that you're making.
I just wanted to say one thing, because I didn't answer your question correctly. And just what Kathy said, you have to look at different ways of getting those physicians involved. Because in this era of electronic medical records and something called community integration physician networks, have you heard of that term, CIPN? Well, these are agreements that insurance companies are making with physicians to keep them in a network, to get them incentive based upon performances. And if those physicians that do not want to get involved, their insurers might want to learn about it, and they do that through electronic medical records. And this is how they collect data, and they look at individuals. And this is transforming across America. A lot of hospitals are forming these unions with physician groups, are getting them involved, and that is the business of medicine. I didn't go to medical school for this, but to survive, I had to learn that. And these physicians may have to learn that in order to get involved.
Great, thank you to our panel. Hopefully hopefully you all have at least taken some of this and will reflect on it for a few days, because you may not realize this. Everything we complain about, things that we need to do, are only going to be solved by you. So you have to think about how you can do it in your own environment to improve what you need to improve. So think about what you can do, because how we got to where we are is because of what you did. And how we're going to get to where we are going to go, again, is not because of one government or one community-based organization or one business. It's going to be you working within your environment to improve healthcare. So thank you very much. Let's give them a hand.